It's 2026 and a New Year's resolution, I think, for every single person over the age of 40 is to ask their primary care doctor about peripheral artery disease, poor circulation, and mainly the legs. Why, you might ask? A recent article published in the Journal of General Internal Medicine analyzed more than 2.3 million patient records from 2,000 plus primary care practices nationwide, and they discovered there is still a striking PAD underdiagnosis gap. And a PAD is more prevalent and deadlier than prostate cancer, colon cancer, and breast cancer combined. And it's really important to get checked for it. But this study shows that only 1% of patients about 40 or over received a credible PAD diagnosis during 2018 to 2022. Yet population-based ABI screening studies, ABI is the blood pressure cuff study where they place blood pressure cuffs in your legs and your arms, measure the differential, which lets a doctor know if you have poor circulation in the legs. Well, these studies suggest the true prevalence, not 1% of the population over the age of 40 should have PAD. Actually, 5.8% to 7.2% of the population should be diagnosed with PAD, meaning about 82 to 86% of PAD cases may remain underdiagnosed today. Essentially, 5 out of 6 patients with PAD are not being identified. And if it's identified early on, walking is the most effective medicine to keep your legs intact. No procedures are ever necessary. If you can catch this early, get your diet in check, take the right medicines, mitigate those risk factors like diabetes and chronic kidney disease, stop smoking, and start walking. But most patients, the reason that they think that they're not getting diagnosed early on is because they have atypical symptoms or are what's considered asymptomatic. This partner study is what it's called, showed that relying on claudication meaning the leg cramps, the cramps in the calves, it actually um, it showed that that alone is not really a great indicator anymore of PAD. And so many primary care doctors and even podiatrists are missing this. So we have Dr. Lily Johnston here. She's a renowned vascular surgeon out of Southern California. She is a co-host of NextGen MD. She has a great YouTube channel that you got to follow, youtube.com/the @ Lily Johnston MD. Make sure to like this video, follow her channel, follow ours as well for more great information like this. But we have her here to talk about this study and what it actually means, because I can imagine, Dr. Johnston, this is really disturbing information because you end up getting these patients when they're too late to treat and they're already a toe stub away from amputation. But this
Absolutely.
is, well, disturbing, right? It's not shocking, unfortunately.
And it's not shocking the number of patients who come to me who already have limb-threatening ischemia, either with rest pain or more commonly tissue loss, meaning a wound that isn't healing on the foot, or dry gangrene, who had no idea they had any problem with their blood vessels. Is It's staggering, and it's tragic because there were so many opportunities to get these patients into the system and try to get the risk factors managed, try to get those blood vessels healthier, before these types of Hail Mary interventions were ever part of the conversation.
And what's interesting to me is the fact that they claim that one of the reasons is that these patients are asymptomatic, meaning that they don't have the textbook claudication. But that is again no surprise to vascular specialists such as yourself, because you recognize that there's a new type, in a sense, of diabetes. It's no longer that large vessel disease that we're used to, caused by smoking in the aorta and the iliac vessels all above the knee. We have this new trending type of PAD that doesn't have the same typical claudication symptoms that help a doctor catch it early on. This is literally a small vessel disease below the knee and into the foot, triggered a lot by diabetes and chronic kidney disease. Can you talk more about that?
I mean, you're absolutely right. We have patients who either are not very active, and so asking them if activity triggers pain is not very helpful because they just don't have enough activity to impair circulation sufficiently to cause the muscle pain. We have other patients that the disease is mostly below the knee or in the feet, and this is classic for our diabetic patients and our patients with chronic kidney disease, who typically, the claudication symptoms, as it is classically described, happen at anatomic level below the area that's narrowed. So if the vessels in the thigh are narrowed, then we get the classic claudication in the calf muscles that they will seize up. I've had some patients who have disease in the calf arteries and the foot arteries who will get a white foot, or maybe it goes numb. But if they have neuropathy, they don't know if it's numb. It's already numb. And sometimes they don't get any symptoms at all because the muscles down there are so small and they're not working very hard that they don't have the symptoms. So it's absolutely possible to have this disease and not have symptoms. The other thing that I would say is even ABI testing requires about a 70 to 80% narrowing to show a decrease in blood flow.
Interesting.
Symptoms, again, will require about a 70 or 80% narrowing to show a symptom. That means you could have a 50% narrowed artery. 50% of the flow channel of the pipe is blocked, and you don't know it because your body can accommodate for an amazing amount of disease before it becomes symptomatic. But if we knew you had plaque at 50%, I know I would go all in trying to figure out how never to make that get to 60 or 70 or 80%.
I love the point that you made about people struggling to walk, and they may not have the classic symptoms of claudication. I mean, not just because of the, neuropathy and that sort of thing, which is typical with a diabetic, but the fact that they're not experiencing the claudication. They might have experienced it one time, right? Maybe years ago, and they got that one leg cramp and they're like, I'm just I'm not going to walk very far very fast anymore. And they just start, right, decreasing, and then they can't remember 2 years ago that that was the reason that they no longer walk that far and or walk that fast. And so they never push themselves to that point that triggers the claudication. And that is literally what Dr. Mark Banaka, he's the lead PI on the STRIDE trial, which was the trial with Ozempic and Wegovy and the semaglutides that showed that the semaglutides were very helpful in improving walking distance, for patients with PAD. But he was saying that the new question, it shouldn't be, do you have claudication? It just should be, can you walk the same distance, or are you walking the same distance as you did a year ago? And if you're not, that's a great place to start trying to figure out why, and to get that testing done to make sure to rule out that it's not a circulation issue.
I love that question. I think that's a great question. And, there are all kinds of other less concerning things. I mean, people have back issues and osteoarthritis of the hip or the knee, they broke something, and there are all kinds of reasons why people might not walk. But there's, the bar to entry here is to get tested is so low. It's an ultrasound, it's a blood pressure cuff. It's really not, that burdensome to get checked and just make sure. Somebody could, I don't know, do a physical examination and check for pulses. If you have bounding pulses in your feet, it's probably not your circulation, although we can talk about that. But generally speaking, we can do a lot to just screen for the presence of this terrible disease.
Yeah, let's talk more about that.
Which part?
You wanna How can they actually feel their foot pulses? Can they actually go down and tell whether they have bounding pulses? Can you trust that?
Uh,
Can a patient go down and actually, feel themselves? I know I always tell people, I have this patient that's in a hospital room in Iowa right now, and he has been diagnosed with vasculitis, but hasn't been diagnosed with PAD, the first question I said, well, is one foot cold? Is the other, colder than the other? And the answer is yes. Well, why have they not checked for peripheral artery disease and poor circulation versus just
Mm.
putting a band-aid on it and giving him some antibiotics? But you as a patient can advocate for yourself by just taking your hands and feeling your feet.
Sure. Yeah, there are two places that we'll check for pulses in the foot. One is on the top of the foot, and the easiest place to find it is if you lift your big toe up, there's a tendon that pops out on the top of your foot, and that pulse should be kind of right to the outside of that tendon that pops up. If not, search around a little bit, but generally, it should be in that area, kind of on the bridge of the foot. And the other is behind your middle ankle bone, so that big bony prominence on the middle part of your ankle. Behind it and under that should be the second pulse that we can feel in the foot. Now, if you can't feel them, it may be fine, right? Some people, those vessels get very shy if your feet are cold, and sometimes they're just hard to appreciate. I had patients today that I actually had a hard time finding in clinic that I thought probably had normal blood flow, but we'll double check because that's what we do. And nevertheless, if you can feel them, that's a pretty positive sign. I had a friend text me a picture of their foot and ask me about some kind of foot problem. And we did this exact same thing. I was like, here, like I circled on the picture, like, here's where you should check to see, can you feel a pulse there? And he's like, yes. I'm like, great. Okay. I feel much better that this is not a vascular crisis or an emergency. So that was reassuring, and absolutely you can do that. If you cannot feel them and you are worried, great, go ask your doctor to check. If they cannot feel it and they are worried, let's get some pictures.
So, from a systems perspective, what changes do you hope to see clinicians and patients commit to so fewer people with PAD fall through the cracks and end up on your doorstep where you have no option but amputation?
I think education and awareness is where we always have to start. And so, reminding every diabetic patient to look at their feet every day, reminding them that they should not walk barefoot, especially if they have neuropathy. I had that conversation with a patient today who was not seeing me for anything in the legs, by the way. They were seeing me for carotid disease, but I examined their feet and we talked about the fact that she
Good
walks
for you.
barefoot, and I don't recommend that. And truly, I think she's going to need me for a foot problem before she ever needs me for the disease in the blood vessels in her neck. So these are all, the just everyday silly little things that we have to do. Now, should we do more imaging and make sure that people are getting ABIs? Should we make sure that we're asking about, can you walk the same distance this year that you could last year? Like, these are very important. And from a clinician standpoint, we need to do better about making sure that doctors know what vascular disease looks and sounds like. So YouTube, like I have given a talk to our internal medicine doctors over lunchtime, and it was 10 minutes, but we said, look, if your patients have pain when they walk, if they have issues, if you can't feel a pulse, if it seems silly, I don't care. Like, send them to me anyway. I would love to examine them, find a bounding pulse, and say, everything's great. You don't need me, right? Like, that's the best day for everybody. But God forbid we miss something and didn't have that opportunity to look into it before it became an emergency. Like, that's the missed opportunity. So I think just being, raising this awareness, and Kym, you do such a great job of this. I am so grateful to know you and to have you spreading this word and sharing all that you've learned with everybody, because this is how we do better.
We're trying, and it is literally it's word of mouth. And the one thing about the success of the Susan G. Komen Foundation that I think really was incredible was they created a groundswell, and that's what we're trying to do, is create a groundswell. And it was interesting. I mentioned the patient that's in the Iowa hospital right now with vasculitis. Well, it was from a previous patient that we had helped, that they ended up recognizing the symptoms and said, you need to call the Global PAD Association's Lifesaver hotline and ask about PAD. And the patient told them, no, 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 I don't have PAD. The doctor didn't diagnose it. And this patient's wife actually said, but they should. You need to talk to Kym. And so late into the evening last night was Sunday. I don't know what day it is anymore. The first real work day back from the holiday. But she said, call me. We were on the phone till late Sunday evening last night, talking about all the questions that they need to ask to ensure that they get a proper vascular evaluation, for that cold foot that they have. So it's just one person helping another, helping another. And actually, I have one more story to share, which I think was interesting. Was we helped a patient in it was in Michigan, on the border, Michigan and Illinois. And this Michigan patient's wife saw a man on a scooter that already had an amputation that just seemed to be, I don't know, just she said he just didn't seem right. He had this tape, on the other leg because he had shorts on. She could see that he had some sort of gauze and that leg was taped up. And so she went up to him and said, "You know what? I don't want you to end up like my husband. I don't want you to lose another leg, and you need to call the hotline." And it's just one by one by one. If everyone took the opportunity to step out and step up to someone they think could use the information, could use the support, could, get the help they need. They really should. And I think that that's what's happening more and more. At least I'm hoping. It takes all of us. It takes the village. It takes everyone in the community. It takes even Heinz, who's sitting here in our live studio audience, just to point out one, to just take a look out, be aware of the people around you, and have the courage to step up and say, hey, call the Leg Saver hotline. Ask your doctor about P.A.D. Get tested, because more likely than not, especially if it's someone over the age of 60, 1 in 5 has P.A.D. And with more than 50%, and correct me if I'm wrong, Dr. Johnston, but last number I saw from the ADA, American Diabetes Association, was more than 50% of American adults are thought to have diabetes, and diabetes is one of the main risk factors for PAD. And 1 in 3 diabetics over the age of 50 has PAD.
Yeah, I mean, no matter how you count it, the numbers are staggering. And I think the other thing that that came out of this paper that Dr. Ross wrote was the idea that if you have any of the other things that we often see in patients with PAD, right? This is hypertension or high blood pressure, elevated cholesterol numbers. If you have ever smoked in your life more than a couple of packs of cigarettes, if you have heart problems of any kind, like all of these increase your risk for PD. Diabetes is a big one, pre-diabetes, all of this. If you have any of those, like just ask your doctor. And I don't think, primary care physicians are withholding this screening from people. I think that just doesn't occur to them when they're managing the blood pressure and the cholesterol and the heart failure and the kidney issues and all of these things. And they're, 12 minutes that they get per year with this patient. It's not that they aren't worried about it but it's not the top of their priority list. But if you as a patient know to ask, your doctor, I think, will more than likely be happy to order those tests for you. So, that's really the key thing, is just know to ask. If you are over 60, if you have any of those other conditions that go along with P.A.D., by all means, get screened.
And I know there's no actual, like you have with, mammograms and colonoscopies and prostate exams, like there's no standard to say, hey, everyone over the age of 50 with a risk factor should be checked. But if you do have a risk factor and you ask to be checked because you're concerned about your walking ability, you're concerned about the neuropathy, you're concerned about a little fatigue in your legs or tingling or whatever it might be, it is covered to get the test. It's covered to get the ABI test, correct?
I mean, truthfully, the average person can do it in the office with a Doppler and a blood pressure cuff, even if you don't get a formal vascular lab study. But yeah, if you're having any symptoms and you have a comorbid diagnosis, then yes, that should be covered, and it shouldn't be a problem.
And
I would
our
hope.
producer Joshua wants us to dive a little bit deeper into the barefoot walking. Is it PAD specific is what he wants to know. And I think it is such an important question because we do have a lot of patients that are in warm weather states like Florida. And I was just on a cruise to Hawaii and I saw so many people just walking barefoot that were severely overweight. And I'm thinking, oh, this is just a disaster waiting to happen. Please, dear goodness, put on a pair of shoes, protect your feet.
Yeah, it's not PAD specific, but it's diabetes specific, and especially if you have neuropathy. So the issue here with barefoot walking is if you cannot feel your feet, then your chances of stepping on something or scraping your foot and getting a wound that you don't know about and having it sit in the mud or the sand and potentially get infected is very high. So it's especially for anybody with neuropathy who cannot feel their feet. You will not know that you are getting blisters or that you have stepped on something or have injured your foot in some way. And that's also why it's so important to either have a mirror or somebody in your home who can look at your feet every day if you cannot see your whole foot. And again, those are for people who cannot feel it. If you and I are out walking barefoot, and you step on, you'll know it right away. Like you'll move your foot if you're about to, step on a nail. But if you have neuropathy, you won't know. That's really the
Yeah, and we
danger.
actually have Heinz here. Heinz, you have a really good point. Go ahead and unmute, and share your point. I think that it's one of the risk factors um, for PAD, should be anyone who has had cancer as well, and or has had any sort of chemo or radiation. That's something that you wished, Heinz, that doctors would have done for you.
I mean, I had it in my leg, but you got people that have breast cancer, lymphomas, all kinds of diseases that they get treated with radiation and or chemotherapy, and uh, they could go for years not knowing they might have problems because nobody told me you need to get a follow-up to the vascular surgeon or a interventional cardiologist or someone like that. So I'm just, bringing it up as maybe that should be well known too.
It's a really good point, Dr. Johnston. Have you seen quite a few? We've had quite a few come in, actually even two in Heinz's area. Heinz was able to help one of our other patients that came to us, and she also had radiation damage, in her legs and her iliac arteries, actually, just as Heinz did. And it might be worth doctors, oncologists saying, hey, while you might be in remission now, for this, let's just get you a full cardiovascular and vascular workup, to follow up and make sure that it didn't cause any damage to your arteries.
Yeah, I mean, in all fairness to the radiation oncologists and I've known a couple, they try very hard to be very precise about where that radiation goes, and they will swear that they're not targeting the blood vessel, and so there should be minimal radiation. But I have also seen plenty of patients who had pelvic radiation for a tumor of one kind or another who ended up with some spillover and damage to the arteries. The neck is another place for it. And it's a little hard to say any cancer patient because not all chemotherapy is toxic to the heart or toxic to the vessels, and not all radiation, again, depending on where it is, like whole breast radiation doesn't typically cause a lot of vascular issues, but never say never. And certainly if you're having symptoms, then by all means, recognize it certainly could be an issue with the blood vessels.
Yeah, I've had quite a few also that have ended up with blood clotting afterwards and ended up with clots more in their aorta than
Mm,
anywhere else that I've seen. That
yeah.
we've had, a few on deck for axillary bifemoral bypasses, and all they needed to do was to, put in a catheter directed delivery of, some clot busting drugs and a little thrombectomy, and they were good to go. But that both the two cases that I had for that one as well were, both they had cancer, they had the treatments, and this came following. Who knows if there was any sort of causal, you know, um, effect, but I can only tell you that this happened and then this happened
Yeah.
in both
Well,
cases.
cancer is a known hypercoagulable state. So if you have an active cancer or malignancy, you are at higher risk for blood clotting. Absolutely. We know that.
Yeah. So final thoughts on this. Where should we go? What should we do with this new information that we have? I think that it's something that patients do need to make the New Year's resolution this year and actually every year to say, hey, when I go to the primary care doctor, first of all, make your annual appointment with your primary care doctor. Do not skip a year. But when you go to the primary care doctor, ask them about PAD. And especially if you have the risk factors, you can make all the difference in the world, just as with Susan G. Komen Foundation, with women, encouraging women to go to their primary care doctors and saying, hey, I want an exam. And that leading to a standard for all women to get over the age of 40 to get tested for breast cancer. That could be the same for PAD. And every person counts.
Yeah. And above and beyond yourself, tell one person, right? Find somebody in your life who needs to know more about this. If they have high blood pressure or they have diabetes, ask them if they've been screened. And if not, make sure that they know what PAD is and what their risk factors are. And again, if everybody tells one more person, we'll double the number of people who are aware of PAD and are going to get screened and make sure that they are in good arterial health.
Fantastic. Because early screening, why is early screening so important for PAD?
Because we have all kinds of things to do to manage the symptoms, because people can walk their way around those areas that are narrowed or blocked. And if we can prevent the revolving door of procedures, as you so eloquently put it, that is the best thing that we know how to do to hopefully save legs and save lives.
Fantastic. Thank you so much, Dr. Lily Johnston. We really appreciate your perspective. We appreciate your time. And we appreciate all you do to save life and limb, not only in your own practice, but by appearing on this weekly show and also on your YouTube channel, youtube.com/the @Lily Johnston MD. Make sure to like this video, subscribe to her channel. She puts out great content each week in partnership with our amazing producer, Joshua. We do appreciate you for making this possible and contributing to our mission to save life and limb. Also, make sure if you are watching, again, our YouTube channel, as well as youtube.com/the @ The Way to My Heart. Happy New Year, everyone.
Thanks, Kim.